and welcome to the September Valleywise Grand Rounds. Um, as with other Valleywise Grand Rounds, keep in mind Megan will be posting the CME code in the chat midway through, and please make sure to mute yourself and turn off your video if you do not want it to be on. This morning, we're welcoming Dr. Kopstick from Texas Tech University Health Science Center in El Paso to discuss how we can bring more trauma-informed care to our daily practice of medicine. Dr. Kopstick is a pediatric intensivist by training, completing his pediatric residency at SUNY Downstate in New York, then his pediatric intensive care fellowship at Oregon Health Science University in Portland, before moving to Texas Tech. He's been very involved in research in trauma-informed care, publishing multiple articles on the topic in the past few years, as well as coordinating a large multi-center study on the topic. And I can think of no better person to discuss this with us than Dr. Kopstick. And with that, I will hand the virtual floor over.
All right. Thank you so much, Rachel. Good morning, everyone. Thank you so much for joining today. Like you said, I'm Dr. Kopstick, Avi Kopstick. I'm an assistant professor of pediatrics and a pediatric intensivist at Texas Tech in El Paso, where I also serve as interim division chief of pediatric critical care medicine. I also have the privilege this past year of being an AAP trauma-informed care champion, which means I had the opportunity to work with a national network of pediatricians who are trying to bring trauma-informed principles into everyday clinical care. It's been a real honor to be here speaking with you all today. Essentially, I'll be talking about what it means to build a trauma-informed care culture, why it matters so much in pediatrics, and how we can start shifting our mindset even in small but meaningful ways. I have no relevant financial relationships with any ineligible companies to disclose, and I won't be discussing any investigational or off-label product use today. This talk is meant purely for educational purposes. All right, so here's what we'll cover. First, I'll try and define what trauma-informed care is. A lot of people sometimes are confused. They think it refers to blunt trauma, but I will first define what TIC is. Then we'll look at some of the barriers that make TIC work hard to implement in real-world pediatric settings. And then finally, I'll offer a few strategies you can use to build a more trauma-informed culture starting where you all are. Okay. So trauma-informed care is essentially a mindset shift. It moves us from asking the question, what's wrong with you, when we're thinking about patients or caregivers or our coworkers, and getting us to ask the question, what happened to you in the past? It recognizes that trauma is widespread, talking about psychological or some sort of like mental health trauma, and that is widespread in our patients, families, and colleagues, and that our systems, the hospitals that we work at, the clinics that we run, our systems can unintentionally re-traumatize people. Trauma-informed care is about creating safety, promoting trust, and empowering patients and families. So SAMHSA, which stands for the Substance Abuse and Mental Health Services Administration, they define trauma as any event or circumstance that is experienced by an individual as physically or emotionally harmful or life-threatening, and an experience that has lasting adverse effects on functioning and well-being. This can include abuse, neglect in early childhood, but also it can include medical trauma, witnessing violence, sudden loss, displacement, all common experiences that pediatric patients and families may have undergone. Many of you are aware or are familiar with this landmark study where a lot of the early excitement around trauma-informed care started, the Adverse Childhood Experiences Study, or the ACEs study. This study was one of the first to show how early trauma, even when not medically related, correlates with poor health outcomes in adulthood. So things like heart disease, diabetes, substance use, depression, these were all correlated with an increased, and in a dose-dependent manner, with an increased amount of adverse childhood experiences that people had presented with. So this study changed how we understand the link between early life stress and long-term health. But this quote really captures, for me at least, what the essence of trauma-informed care is. So this comes from the 2002 book, which was by Harrison Fallot, called Envisioning a Trauma-Informed Service System. So this was one of the first major works to introduce and formalize the trauma-informed care framework. So when we talk about trauma-informed care, this is kind of where most of it started in its current form in 2022. So Harrison Fallot essentially argued that once trauma will move to the center of understanding, and once we recognize how deeply it can shape people's lives and behavior, it then becomes impossible to go back to the old ways of delivering care. They, in their book, called for a total redesign of service systems to avoid re-traumatizing people who are already vulnerable. And it's remarkable to think that this framework has only been around for a little over 20 years, and now we're seeing an explosion of interest in trauma-informed care in pediatrics. I applied in critical care, in hospital systems, outpatient, medical education. A lot of different domains are now applying this framework. It's not just therapists or social workers, it's physicians, nurses, administrators, and medical educators. Because once you see trauma, you cannot unsee it and the effects it has. Once we understand how our systems can perpetuate harm, we then have responsibility to do things differently, not just at the bedside, but across our entire cultures of care. All right, let's talk a little bit just to get a background, and because we're all very interested as scientists and physicians and physician scientists. So we'll talk a little bit about the neuroscience of trauma. So when we experience trauma, when individuals experience trauma, especially early on in life, it actually reshapes how our brain processes stress. And this is not just a psychological response, it's actually a biological one. So there are key regions of the brain that are involved here. So you have the amygdala, the hippocampus, the insula, and eventually when the prefrontal cortex comes online in adolescence is very involved in this as well. Right now, and so in a lot of trauma-informed care settings, we like to zero in on the amygdala because that's the part of the brain that scans for danger and then alerts us to threat. It's essentially our internal alarm system. So what trauma does is that it primes the amygdala to be hypersensitive to threats. And that's so basically once something is experienced as dangerous or threatening, the amygdala learns that and then tells individuals to avoid it. And then that sensitivity doesn't go away. The amygdala doesn't really ever forget what scared it. Instead, what then has to happen is that over time, another part of the brain, which is called the basolateral amygdala, has to actively relearn that certain cues are no longer dangerous. And this process of calming the nervous system, it's not passive, it's an active process, effortful and constant, especially for kids and especially in environments that still feel unpredictable, chaotic, or unsafe. So like hospitals can sometimes be. So when we see a child or caregiver who's screaming, shutting down, clingy, or angry, we're not obviously trauma-informed care and understanding of this neuroscience allows us to kind of think that we're not seeing necessarily bad behavior. We're seeing a brain that's actually doing what it is wired to do to survive. And trauma-informed care means recognizing that we need to create conditions where new wiring has a chance to take root and then reinforce itself. So why does this matter to us as pediatricians? Well, first of all, because the kids and the families that we treat are very vulnerable. They often don't have full control over their environments or their circumstances. Also, pediatric medicine itself can be traumatic, even when we're doing everything right. Trauma-informed care gives us a way to promote healing, not just focus on, the treatment that we're doing in that moment. So the general framework has been established by SAMHSA again, and they've essentially published 6 core principles that form the backbone of trauma-informed care. These principles shouldn't only guide how we treat patients, they should also shape how we treat our colleagues, our teams, and ourselves. So safety, that means creating physical and emotional environments where people feel secure. That can be as simple as explaining what's about to happen before doing a procedure or ensuring family has privacy during difficult moments. Trustworthy and transparency ensures that for people who've experienced trauma, they often struggle with trust. So we must begin to earn that trust by being consistent, clear, and honest, even when things are hard or uncertain. Peer support recognizes that healing doesn't happen in isolation. Families often benefit from connection with others who've been through similar experiences. And in our clinical teams, peer support can be a buffer against burnout and vicarious trauma. Collaboration and mutuality is about leveling power dynamics. Instead of doing things to patients or for families, we do it with them. It also means inviting input from all members of the care team, not just the ones with the longest titles. So family-centered rounds and practices like that. Empowerment, voice, and choice. Trauma often strips people of their agency. In medicine, even small choices, like letting a child choose which arm gets the blood pressure cuff, can help restore a sense of control. And finally, cultural, historical, and gender awareness attest to the fact that trauma doesn't exist in our society in a vacuum. It's shaped by systemic inequalities, identity, and lived experience. So we must strive to provide care that is culturally responsive and identity affirming. Trauma shows up everywhere in our systems. When patients and family come to us, they're often already dysregulated. They're sick. They're asking for help. And honestly, a lot of times, so are we. Our systems are fast-paced, overburdened, and not always designed with empathy in mind. Let me try to give you a recent example that I saw. A mother who had a known psychiatric history brought her 8-year-old autistic daughter to the ER. The child had blood in her underwear, and the mother was terrified. She thought her daughter might have been sexually assaulted. She wasn't demanding answers. She wanted someone to listen to help make sense of what she was seeing. Instead, the emergency team focused on the mother, not the child. They told her they needed to transfer the daughter from a pediatric ER to the adult ER, which was located at a different hospital, in order to be seen by a sane nurse. And then the mother became distressed. She didn't understand the term sane nurse, and she kept repeating, but she's not insane, she just needs to be checked. And then things escalated. The staff labeled the mom and used words like crazy and aggressive. And eventually, unfortunately, she was placed in emergency detention order. She basically got EDO'd. She was tackled, restrained, and taken away, and her daughter, already overwhelmed, autistic, and nonverbal, was left behind. Confused, distressed, and now without her mother, she had to be admitted to the pediatric ward. So now I wasn't there in the beginning, and I'm sure the people in the ER were trying to do what they thought was best and safest for the daughter and the mother. But from where I sat, this was a clear example about how trauma can be compounded by the system. When we pathologize fear instead of understanding it, we can re-traumatize patients and their caregivers. When we respond to distress with control instead of curiosity, we can re-traumatize the patients and the caregiver. And the hardest truth is we cannot address trauma in patients and families if we don't also address the trauma that's baked in to our medical culture. How we handle power, urgency, risk, and behavior. Trauma-informed care isn't just about changing how we talk, it's about shifting also how we think. And the truth that we all need to internalize is this: trauma is common. By some estimates, 60 to 70% of children will experience at least one traumatic event by the time they reach adulthood. And it's not just due to overt abuse. Trauma includes medical procedures that can be felt as terrifying. The death of a loved one, a move, a separation, a night in foster care, living in a car, watching someone get arrested, going to school hungry. These are everyday realities for many of our patients. They're not rare exceptions. So if we know trauma is this prevalent, then we need to treat it the way we would treat infection, like infection prevention that is prevalent. Trauma-informed care needs to be used as a universal precaution. We foam in and out of every patient room, not because we know the patient has a specific bug, but because we don't know. Trauma-informed care should be the same. Every time we enter a patient encounter, we must assume the possibility of trauma is there. And then we can act accordingly with gentleness, clarity, and readiness to listen with curiosity. And that's how we will protect against re-traumatization. And that's how we'll begin to rebuild trust with our patients, their caregivers, and our colleagues. Because not to diminish what our patients and families go through or to ever compare our experiences with them, and certainly not to make this about us, but we should also recognize that, that the trauma around us doesn't stop at the threshold of our own bodies. We are part of the system too. We work in these high stress environments. Oftentimes we are understaffed, emotionally overloaded, maybe navigating grief, death, conflict, moral distress. As such, we can become dysregulated ourselves as well. This dynamic can even be thought of as like a parallel process. which is the idea that what patients and families experience can be mirrored in the experiences of those who care for them. So when a caregiver comes in guarded or withdrawal, and we feel ourselves getting cold or rigid in response, we can understand that as just a parallel process. When a parent is dysregulated and we start escalating to regain control, we can think of that as the parallel process. And what matters is this: building trauma-informed culture is not going to be just for our patients. It's also a pathway to protect ourselves. It'll be a way to reduce burnout, increase meaning in our work, and reconnect with why we do this work in the first place. Trauma-informed care is not just about healing others. It can also be a way back to healing our own fractured spaces. So hopefully by now everyone can appreciate this, but again, I want to emphasize it nevertheless. Trauma-informed care is not just about being nice, and it's not necessarily extra work. It's a rigorous, evidence-supported framework for healing. It requires system-level thinking. We need to change policies, language, and workflows. It moves beyond empathy into structural transformation. And so, again, this is just another way that I kind of conceptualize what trauma-informed care is. Because one of the most important things trauma-informed care asks us to reconsider is how we think about people work. Because humans are not linear creatures. We don't behave like machines. We don't follow neat chains of cause and effects. We're complex systems, we're dynamical systems, and most of the time, human beings are unpredictable, very layered, but more importantly, shaped by early conditions in a way we can't always see fully. So trauma science helps us see that people can have sensitive dependence on initial conditions, which is a really fancy way of just saying that even small early experiences can have cascading effects on how we how people experience and interpret the world, how we regulate, how we connect with each other, and how we protect ourselves. Trauma-informed care gives us another lens. Instead of asking, how do I control this behavior, we can ask what condition what condition would allow this person to feel safe, to grow, and to learn to trust. Trauma-informed care allows spaces for pluralism in thought, basically for holding multiple truths at once, and for seeing beyond simple labels, and for making room for stories that don't always fit cleanly into the clinical frameworks that we're taught. It invites us to meet people as whole, complex beings, just like we are. But then what gets in the way? So for one, there's this idea that we already do this. Other barriers that people often talk about include time pressure, burnout, institutional inertia, or fear of looking soft. But these are all things that trauma-informed care is actually meant to help with. So how should we start? Well, let's start small. So normalizing emotional check-ins during rounds, integrating trauma screenings into visits, validating family distress, even when there's nothing we can do. Of course, avoiding labeling behavior without context, and then using first-person dignity-based language. These sound really simple. They're not always easy, especially when we are ourselves feeling angry or tired, or holding aftermath of harm we didn't cause but still have to witness. So for example, I think about that mom I mentioned earlier. At first I felt really upset at the ER team, at the system, at just the brokenness of it all. And honestly, I wanted to call it for what it felt like. It was cruel to that mom and that child, maybe even violent, maybe worse. But here's the thing: calling people cruel doesn't create effective change. So I don't know if people know of the story of Ignaz Semmelweis, but he had to learn that the hard way. He essentially was a Hungarian physician who in the 1840s realized that obstetricians were essentially, he thought that obstetricians were essentially killing women during childbirth, not because of malice, but because they were moving between autopsies and delivering babies without washing their hands. And he actually introduced what would become the first universal precaution, which was hand washing with chlorinated lime. And then it worked, mortality rates plummet. But the problem was Semmelweis was very angry, and he couldn't believe his colleagues wouldn't accept his evidence. He called them murderers. He raged in open letters, but then what ended up happening is they dismissed him, they ostracized him, and he actually ended up dying in an asylum from sepsis which was the thing he was trying to prevent in his patients. So I think about that when I want to call out harm, because sitting with harm is hard. But if we want to change people, we can't ever lead with shame. We need these trauma-informed care frameworks, not finger pointing. We need culture change. Trauma-informed care offers us this path. It doesn't excuse harm, but helps us respond to it in ways that can build something bigger. So as we think about actually how to implement trauma-informed care in our clinical settings, one of the important things recommended by the AAP is using evidence-based screening tools. And this becomes a really critical piece. We can't respond to trauma symptoms if we don't ask about them. And yet many of the tools that are currently in circulations, like ACEs screeners or positive childhood experience screeners, these currently lack robust evidence of predictive validity or clinical utility. So what we really need are tools that help us identify trauma symptomatology, not just exposure to trauma, and that are specifically designed for pediatric populations. So here I'm showing you the Pediatric Trauma Symptom Screening Tool, or the PTSST. Essentially, it's a brief screener that can be used in clinics or even in the hospital. It's validated, and it essentially helps clinicians assess whether a child is exhibiting trauma-related symptoms that might warrant further support. This can help create structured ways to recognize dysregulations that might otherwise be missed or misunderstood. And if we're serious about becoming trauma-informed, we have to be serious about using evidence-based instruments to guide our understandings, not just relying on instincts or assumptions. So this slide essentially shows a mnemonic that was developed by the AAP National Center for Relational Health and Trauma-Informed Care. This is essentially the AAP's new platform. If you Google AAP National Center for Relational Health and Trauma-Informed Care, you'll find a lot of educational material for trauma-informed care. But there's two mnemonics that are incredibly important that we try to teach as trauma-informed champions. It's frayed and threads. So frayed is meant to describe what trauma-exposed or adversely affected children might look like over time, especially in the absence of resilience-building protective factors. So each letter represents a common outcome or potentially a warning sign for a patient who might have experienced trauma. So what I like about this framework is that it reminds us that kids don't always look traumatized, and we don't always get that history, but they often look like kids who are having behavioral challenges. And until we remember that those behaviors are often adaptations to something overwhelming, confusing, or unsafe. And just like frayed fabrics, these are signs of unraveling, not because the child is broken, but because the environment around them hasn't given them enough support to hold it all together. So the question becomes, what can we do individually and systemically to start reweaving those threads? So threads is another mnemonic from the AAP's National Center for Relational Health and Trauma-Informed Care. It highlights the aspects of resilience that we want to notice, nurture, and reinforce in our patients and in their caregivers and even in ourselves. They're not just buzzwords, they're clinical tools. So if a child has dysregulated behavior, but you notice that they light up when they talk about their favorite teacher or their pet or a comic book, you're seeing engagement, agency, and hope. If they're falling apart during the day, but they tell you that they still tuck themselves in every night, then they have a routine that they can fall back on, and that's regulation. That's going to regulate them. Our job is not necessarily, or I mean, if we could, we would eliminate every hardship, but that's not possible. But what we can do is look for the threads and then find ways to weave them more tightly into the fabric of care. Because again, healing doesn't come from what we remove necessarily. It also comes from what we can reinforce. And what we're trying to enforce is safety and connection that can help patients start to mend. So again, we don't have to overhaul our entire practice overnight. Everyone should be able to start where you are. One conversation, one shift in language, one pause before reaction. Even small interventions done with mindfulness and intention can build trust and healing. So SAMHSA summarizes this trauma-informed approach with 4 R's. And this is where we can at least start, with fundamental small actions. Recognizing, so it starts with realizing the widespread impact of trauma. which is what I've been talking, recognizing signs and symptoms of trauma. So that would be using the PTSST or the frayed type of mnemonic, respond by integrating knowledge into practice. And that could be just with universal precautions. And there are, are a lot of different ways that we could integrate this knowledge into our practice. And a lot of that is going to be on that AAP website. But for me, the most important is going to be resist re-traumatization. And especially when I'm dealing with patients in the hospital, in the PICU, because there's a lot of opportunities for patients to be re-traumatized in that setting. And for me, my biggest responsibility that I hold at all times is to avoid that as much as possible. Um, so, um, uh, as we're getting close to the later parts of my talk, I actually want to take us back in time for just a moment, which is back to the early days of inpatient pediatric care. So there was a mystery that haunted physicians for decades. In the late 19th and early 20th centuries, doctors began noticing something deeply alarming, that infants in clean, well-maintained hospitals receiving what was considered proper care at the time were essentially failing to thrive. They weren't sick in the way that we typically think. They weren't coming in with infections or they didn't have congenital anomalies, but these babies were essentially pining and wasting away and sometimes had a really high mortality rate. Floyd Crandall, who was a pediatrician at the time, wrote in 1897 and captured the collective confusion pretty well when he said, "It is difficult to understand why infants placed in comfortable and beautiful surroundings should after a time begin to pine away and gradually waste away. Despite all the medical advancements at the time, this condition, what would eventually be called hospitalism, remained really poorly understood. However, the popular story is that 40 years later, another psychoanalyst named Rene Spitz showed up and solved the puzzle. He argued that hospitalism wasn't about poor hygiene or inadequate food. He said it was actually about emotional and relational deprivation, that infants were dying not from what was medically missing, but from what was emotionally absent. Spitz's work is often credited with triggering a paradigm shift or a new way of seeing the problem. But a lot of good stories, I have to say, I believe that that version is a little too tidy. The idea of a paradigm shift, it's more of a historiographic myth or narrative device than an actual historical reality. So paradigm shift, as some people might know, was first popularized by Thomas Kuhn in the 1960s. And it helped us make sense of scientific change. But in truth, most shifts in medicine are more gradual and messy, and they can be contested, and they often involve competing ideas and kind of the slow turn of experience. So if you actually read Crandall's paper from 1897 before Spitz, what you'll see is he already understood that the children were dying, and he understood that it was more about nutrition and bedding. He wrote about how personal care was more than just baths and bottles, how babies needed to be held, repositioned, and allowed to move. He talked about the fact that there was inadequate staffing. So there was not necessarily bad nurses, just they didn't have enough nurses for all the infants that were there. He even recommended a staffing model where one nurse should care for no more than 4 or 5 infants, in some cases just 2. And I'm pretty sure we still use those staffing ratios in our hospital. And he also warned against judging hospital purely on mortality rates, especially when they were already serving high-risk populations, which were babies born into poverty, orphan, neglected, and sometimes already dying on arrival. One report he cited found that 2/3 of infants under 6 months were already suffering from marasmus when they arrived. Many had been drugged with paregoric or opium-based soothing syrup just to keep them quiet. So then, was hospitalized solved by a new single theory in 1945? No, it was a complex, multifactorial issue that we slowly came to understand over time with better observation, better language, and better tools. And that's why I bring this up, because I think it's a good reminder for us today. We don't always need a revolution in medicine, a revolution in the way we treat patients, a revolution in science. Sometimes we just need better frameworks for understanding what we're already seeing. And trauma-informed care can give us that framework. It gives us the vocabulary, the scaffolding, and the cultural permission to say something deeper is happening here, something relational. and that in the hospitals and every time we take care of these patients, we can do better. So bringing all this together, essentially what trauma-informed care tries to say is that trauma is common and it affects how people engage with care. It's not a buzzword, it's a meaningful evidence-based approach, and that systems, not just individuals, are what needs to change. We can start small, we can stay curious, and this will help us keep going. These days, it seems that everyone is talking about precision medicine. The idea is basically we can tailor treatment to individuals based on genetics, biomarkers, data, risk profiles, and that's very important. But if from a broader view, precision medicine doesn't just need to be about molecular pathways or targeted therapies. Potentially, precision medicine can also be about how people are wired emotionally and what they've lived through. And I truly believe that trauma-informed care, if done correctly and appropriately at the bedside, can be considered precision medicine because it's personalized, it's compassionate. It's about understanding that each patient enters our care with a unique context, a unique nervous system, a unique history, a unique way of interpreting the world around them. And we can call that trauma-informed care, or we can call it personalized and compassionate care. But what we're really talking about is knowing our patients well enough, not just clinically, but also relationally, to offer care that best fits them in their time that they're presenting. It's precise, not because it's high tech, but because it's human. And if we can do it well, it can be some of the most effective and most healing care that we can offer. So I left a little bit of extra time for questions because I was hoping for more of a discussion. I mean, available, but I really would love to just have a discussion and basically, care that you or you make that more common care. What small changes, something deceptively simple, could shift our environments from what patients see as stressful to safe. So from transactional relation. Again, we don't have to fix everything at once. It would be impossible. But every small shift that we can take that's trauma-informed, every gesture of attunement, transparency, or trust, these things can begin to shift the culture. So thank you again for spending this time, and I hope to open this up to an interesting discussion if people would like to ask questions or share their thoughts.
All right. Well, first, all right. I was going to say I don't see any comments yet, but now there is one. So we have a question. And I was wondering about our so well from chat, and it was asking if you have any suggestions on how to emphasize how important this is for the C-suite. So to try to get higher ups on board with this as well.
I mean, it could be difficult, and I think a lot of my colleagues have been facing these challenges. I think it starts with creating relationships and joining kind of the community of practice around trauma-informed care and learning from each other, all of the strategies that different people have taken. I think even with the C-suite, we need to take a trauma-informed approach and understand what they're experiencing and what motivates them and what historically has happened to them. So, for example, if you work in a hospital that has been unfortunately, gone through bankruptcy or gone through really, bad patient deaths, that have been publicized, what you'll end up seeing is a C-suite that becomes very rigid, and not very much open to changing cultures, and it becomes really difficult. And then there are other C-suites that might have a very kind of rigid historical and cultural context that they've now shown up in. And so really taking a trauma-informed care approach and really trying to understand what it is that the C-suite wants and and trying to appreciate that and have those conversations with them. But I don't, there's no way to convince them just by saying it's, I would hope every C-suite would be open to saying it improves safety and it decreased costs, but sometimes that's not necessarily what every C-suite is going to be motivated by. So I think it is challenging. I think a lot of my colleagues have faced those challenges. There is a group called TIHCER, it's spelled TIHCER. It's the Trauma Informed Healthcare Education Group. And a lot of people I can think of have talked about this in that group. So, if that wasn't necessarily the point of this talk, but definitely it's part of the broader conversation. And in the references, leading organizations from burnout to trauma from resilience is a editorial that I wrote, or a commentary that I wrote along with some of those people in that group about that specific question.
All right. There's much appreciation in the chat. One thing I wanted to bring up, we do have a lot of people on this Grand Rounds from both Phoenix Children as well as Valleywise. At Valleywise, we have Epic, and on the side, it brings up a list of the social drivers and different social concerns, financial, everything else that if you click on it, automatically pops up. But it's been helpful for me, at least, to be able to see that and get an idea, especially when discharging, what I might be looking at, where they're coming from, where they're going back to. Nothing protocolized or anything else, but I know at least in our EMR system, it's been built in to make it very easily accessible on my homepage to see that. I don't know if that exists in the Phoenix Children's or any of the outpatient clinic systems. Then there's another question of what do you think will be the biggest barrier for a clinical staff not to be trauma informed?
A lot of people, and this just goes to my feelings more as like implementation scientist than thinking about this as a trauma-informed care. But again, trauma-informed care, it kind of touches all of these different domains, because I would love to say the biggest barrier is just not enough people are getting the education, not enough people are hearing the talks, but that's obviously not going to be true. From an implementation science standpoint, we know that education itself is not going to be one of the strongest type of interventions that we can take. And I think so. One study that we are currently doing, it's called the OTRA. Essentially, the OTRA was a study. It stands for Occupational Trauma and Resilience Assessment. So it was essentially a tool to measure trauma-informed culture in, it was originally developed by Lauren Brown in HIV clinics. So essentially the OTRA, it is a survey for the healthcare staff, and tries to measure the trauma-informed and resilience culture. And then there's another survey called the OTRA-PREM, which is for the patients to take to see, is the clinic as trauma-informed as everyone kind of thinks it is. And so right now we are doing that study, the OTRA, and we've adapted it to do it in a PICU setting. So we've only done 3 sites so far. So it's been Lurie, OHSU, and El Paso Children's. We've distributed this survey. And, I think what we've essentially found was that kind of similar challenges such as burnout and job satisfaction definitely go in line with a lot of the trauma. They're correlating. And so I'm not going to say one causes the other. All I can say is they kind of go together. And my personal, feeling, and again, we're so early in all the research that I obviously can't say what is going to be the biggest barrier, but I think it's the same thing that's dysregulating everybody. It's all of the things that are dysregulating us in our environments is going to prevent us from regulating ourselves so that we can help regulate other people. Because, essentially human beings, the way we interact with each other, we're basically tuning forks. And if we are dysregulated because everything in our environment, and we talked about EPIC, I mean, if the EMR is causing too much burden, that's going to dysregulate. The more we bring AI into doing like AI scribing and other way to decrease our I mean, all these things essentially come together to create either a regulated or a dysregulated system. So education can help, but that's not going to decrease the barriers to becoming trauma informed. I think we do need to, the 4 pillars was realize, recognize, so the realizing and the recognizing is about the education. But before we can get to that, we have to look at our system with, again, a trauma informed type of mindset and framework and say, how can we better regulate our system? And then we can make our systems more trauma informed. So, it takes leaders, and that's why we wrote this article, Leading Organizations from Burnout to Trauma-Informed Resilience. We are really trying to focus on who people, we call them change makers within institutions, and it could be anybody from the C-suite down to residents and interns and volunteers. Anyone who wants to affect change within the system can become more trauma-informed and then help to lead the system to becoming, everyone could be trauma-informed all together. But it'll take those kind of change makers, if that makes sense.
And there's a comment that I think goes along with what could be a barrier to continued trauma-informed care is, I think the other issue with trauma-informed care is the importance of ongoing reflection, because even with training, we can easily be influenced by internal and external stressors and forget. So part of the paradigm shift is to accept this has to be ongoing. It doesn't just happen after being trained. Um, so I think that is another challenge that we have, that we have to keep doing this and keep learning.
I mean, I think that's a great comment. And I think everyone here, we're all lifelong learners, and so it'll make it easier for us. The retraining and the relearning, at least for trauma-informed care, what I found, it's really just opening yourselves up to stories, and really trying to appreciate, all the stories of the patients and trying to understand where they're coming from. And just being curious, you'll constantly be relearning those lessons. And if you kind of get into that frequency, and that's why, Harrison Fallot said, once you start being trauma informed, you can't see the world any different. I think, we understand cognitively that there are adverse childhood experiences, people go through traumatic events, but until we kind of tune ourselves to that frequency of being curious about the story and kind of phenomenologically what the experience is like, then it doesn't become active learning anymore. It just becomes kind of getting on that, same type of frequency every time and learning more and more and appreciating more and more. there's a lot of other things that have brought me to the point where I am right now, in trauma informed. It's, some people can see that it's very much influenced by qualitative research that I've done. So I did a study, it was a phenomenological study on residents' experience in the PICU. And we took a trauma informed type of lens. And I can talk a little bit about that if people are interested. But essentially, what we found was residents who go through the PICU, they experience that rotation as traumatizing. They do end up getting a really great important lesson, which is they feel more comfortable, quote, with taking care of critically ill children, which I think is an incredibly important kind of skill for residents to learn. But then they did experience kind of a period of acute traumatic stress up to about 4 weeks after their PICU rotation. And so again, that's an incredibly important finding and study, and something that I'm trying to research further. But what I would say is it was that act of learning how to do qualitative research and phenomenological research that has now helped me be a little bit more in tune to hearing the stories and understanding the experiences from an emotional and philosophical type of way, opening myself up to more of a pluralistic approach to caring for my patients, if that makes sense.
That does make sense. Are there any other questions at this time?
So this, and so I'll just spend a little time going over this QR code here. So essentially, this is a website that I created. This was when I was first doing a workshop at PAS. So we did a workshop and it was developed for the PICU. It was basically how to make the PICU more trauma informed. We had about 30 participants. And what I did for that was basically create these group role-playing exercises for people who wanted to do more interactive exercises. And then there's also individual self-reflection exercises there as well. And after we did it at PAS for PICU, it was really interesting. We were able to develop kind of a tip sheet for developing more trauma-informed PICU environments. After PAS, I was asked to do this more for a general hospital, so just anybody in the hospital. It doesn't necessarily have to be pediatrics. And so we generalized these role-playing exercises. And essentially, you can click on them and they're the roles. What happens is everyone can look at it with their phone, and you can click on everyone chooses a role. So let's say I choose patient. It gives me a prompt for what to do next as the patient. So the reason that I created this is I was trying to provide some open access type of exercises that anyone in any setting can do. So if anyone's interested, just grabbing, let's say you're in a group and you're on your ward rotation, and it's a group of like 6 of you, then you can do some of these exercises if you're interested. So for every exercise, there are roles for patients, caregiver, resident, physician, attending physician, and then a bedside RN. But, everyone could be creative with how they would like those roles to be. The individual exercises, they're more like self-reflection exercises. So I essentially provided 6 topics that you read through. And basically all of these self-reflection exercises, they start with some like news article or something from the patient's point of view. And then there are some questions to self-reflect. And there's also some academic articles in there as well. And then if you click on it, we also did another workshop at Learn, Serve, Lead for the AAMC. That was in 2024. And I basically put all of that on this website as well. And we split for that workshop, we split it into Learn, which was for the learners, like the medical students. Serve, and then leads. So a lot of the information, there's cases for kind of the C-suite and, going through those type of thoughts. And again, there's some role playing in cases as well. But I think what's also really great on that um, page is that there's a summary of resources that we included that essentially I've included here as well. So the up to date, they recently published up to date for trauma-informed care for both pediatrics and adult medicine. I think those were both published just last year. So if anyone hasn't had a chance to look through that, that's an incredible resource. And I know some of the people who worked on that, and they are really phenomenal. But then there's a few more resources and the links to TISER and the trauma-informed care toolkits that can be found on this website. And then I think there's also opportunity to give some feedback if you would like. I would really appreciate it. So if you go to this website and you click on give feedback, you could put your name. If you don't want to put your name, just put anonymous, that's fine. And then email, you can again put whatever you want, but the comments to me are the most important. Yeah, and if you try out the role-playing exercises, or if you do some, small group exercises with some of this, and, anyone can always reach out to me. I'm happy to share any of my slides, happy to share any of my resources. And, if you're interested in doing more work within, research within this field, I'm, happy to share with you more what we're doing. We're also doing some post-intensive care syndrome work. Yeah, and it keeps branching out. So it's been really exciting.
Thank you. This has been a great presentation and a great reminder of what we need to consider outside of all the facts and data and everything else that we memorize, that we need to think outside of that. So this has been great background as well as action items and things we can do. I really appreciate it.
Thank you so much for inviting me. I'm just really honored to be here today. So thank you.